MD, is a professor emeritus of pathology at the University of Texas Southwestern Medical Center in Dallas, Texas. Dr. Burns did his undergraduate work at Baylor University, where he was the recipient of a Robert Welch Foundation scholarship, graduating with a degree in chemistry. He attended medical school at the University of Texas Southwestern Medical School, graduating in 1978. He completed 4 years of residency in anatomic and clinical pathology at Parkland Memorial Hospital and UT Southwestern affiliated hospitals, and subsequently completed fellowships in surgical pathology and neuropathology at the same institution. Dr. Burns was a full-time faculty member in the Department of Pathology at UT Southwestern from 1984 until 2022, serving as Associate Director of the Division of Neuropathology under Dr. Charles White. During his tenure as a full-time faculty member, he divided his time between undergraduate and graduate medical education, administrative positions, collaborative research with multiple UT Southwestern laboratories, and clinical neuropathology, with a special emphasis on neuromuscular pathology and autopsy pathology. He has published over 150 peer-reviewed papers, has authored 11 book chapters, and is the co-author of 2 textbooks. He is grateful to have received 30 teaching awards from medical students and residents at UT Southwestern, and in 2016 was the recipient of a University of Texas Regents Outstanding Teacher Award and a Minnie Stevens Piper Professorship. Since his retirement in 2022, Dr. Burns has continued to participate in teaching activities, consultations, and committee work at UT Southwestern. When away from work, he is an avid fly fisherman, fly tyer, and student of history, and cherishes time with his family, including his brand new granddaughter that was just born October 3rd.
Thank you. I'm going to go ahead and share my screen now. Very good. Hang on one second. All right. With that, I'd like to thank everybody for joining me this morning. A colleague some time ago suggested that this might be a good opportunity to spend a little time talking about some neuroanatomy that's relevant to the diseases that we encounter in the practice of neuropathology. And I know that most of these teaching rounds are more disease-oriented, and we'll mention a few relevant diseases by way of illustration. But the main focus of this is going to be an anatomy-related topic, specifically functional neuroanatomy of the basal ganglia. I have no relevant financial relationships, and since I retired, not so many finances either. The learning objectives are summarized here. We're going to begin with a few comments about the major components of the basal ganglia. Just for orientation purposes, we'll talk about the major receptive area, the major sources of input to the basal ganglia and the nature of those inputs, the sources of projections outside, that is leaving the basal ganglia, and the major targets of these projections. And we'll spend some time, in addition, talking about the afferent and efferent connections of individual basal ganglia nuclei. This last part, the individual basal ganglia nuclei, is not presented to overwhelm you with details, but rather it's to allow us to segue into a discussion of the indirect and direct pathways in the basal ganglia. We'll talk about these 2 pathways, the individual nuclei, the sequence in which they're activated, and the net effects of activation of the direct and indirect basal ganglia pathways. We'll also make a few comments about the major functional domains that are influenced about basal ganglia activity. We teach the basal ganglia typically as a component of the motor system, and while that's certainly accurate, it's an incomplete description of what the basal ganglia do. They actually have influences that extend far beyond the classic motor pathways. We're then going to segue into a discussion of 3 really well-known diseases, hemibolismus or hemibolism, Huntington disease, and Parkinson disease, and make a few comments about how our understanding of basal ganglia circuitry can help us understand at least some of the manifestations of these disorders. Our order of presentation is as follows. We'll begin with an overview of the components of the basal ganglia, input and targets, a review of the individual basal ganglia nuclei and their connections, and then we'll turn our attention to the direct and indirect basal ganglia pathways and the domains influenced by these pathways. We'll conclude with a discussion of the abnormalities in basal ganglia circuitry that are associated with a couple of classic hyperkinetic disorders and a classic hypokinetic disturbance. So where are the basal ganglia? Well, the basal ganglia lie deep within the brain, as you all know. Most of the components of the basal ganglia are pictured here. You can see the caudate nucleus. Let's see if I can get my laser pointer working here. Laser pointer. The caudate nucleus shown here, looping around in a long C-shaped tail. It's that tail that gives the caudate its name, of course. A closely related component to the caudate that I'm highlighting here is the putamen. It literally means lopped off, and in the coronal sections, we'll see why that's appropriate. Now, an area that you can't see here, but that we'll see in coronal sections, is also a forebrain derivative, namely the globus pallidus. A diencephalic structure that's a component of the basal ganglia is highlighted here. That is the subthalamic nucleus, and a very closely associated mesencephalic structure, the substantia nigra, rounds out the basal ganglia. Now, the components of the basal ganglia are listed in word form here, and I would add that the definitions of what constitute the basal ganglia are many. Some people include more structures than this. Some people, for example, would include the amygdala, the pedunculopontine nucleus, and the rostral pons. But this, to me, represents the nuts and bolts of the basal ganglia and can provide us with a foundation to understand how the basal ganglia work. Now, what are the basal ganglia afferents? That is, sources of information projecting to the basal ganglia. Well, these come from two major sources, namely the cerebral cortex. And when I say cerebral cortex, I mean virtually all areas of the cerebral cortex, not just the motor cortex and related areas. And a second major source of input to the basal ganglia is the thalamus. We're not going to emphasize the thalamostriate connections too much in this talk, but for completeness, I would mention that they are there. Most afferent projections, that is coming outside of the basal ganglia into the basal ganglia, are received by the striatum. The striatum comprises the caudate, the putamen, and the ventral striatum. The efferent projections, that is, projections leaving the basal ganglia, head primarily to the thalamus. There are additional descending projections to the pedunculopontine nucleus in the upper pons that have influences, among other things, on the reticular activating system. Most efferent projections from the globus pallidus from the basal ganglia, travel from the internal segment of the globus pallidus and the substantia nigra. The globus pallidus, and we'll come back to this, is subdivided into external and internal segments. And again, the internal segment is the major pathway for efferent projections. Now, projections leaving the globus pallidus to external sites travel via two major pathways, namely the ansa lenticularis and the fasciculus lenticularis. And for review purposes, I'll just illustrate those here. Now, I know that most of the questions on boards these days have to do with molecular aberrations and tumors and so forth. I would mention, though, that at least back in the dark ages, when I took the boards, there was some neuroanatomy on this. And one of the questions was, what makes up the thalamic fasciculus? You know, the thalamic fasciculus, which is 4L's field H1, is made up of a junction or unification of the lenticular fasciculus and the looping ansa lenticularis, joined by ascending pathways from deep cerebellar nuclei. I missed that board question, but hopefully you won't if they ask it this time. Now, the overview of basal ganglia circuitry in very simplified form is shown here. It is classically presented as a unidirectional flow beginning in the cerebral cortex, heading to the basal ganglia to the thalamus, and the thalamus in turn influencing the activity of the cerebral cortex. There are many layers of complexity over that, and one layer of complexity that I'll add here is that this is not truly a unidirectional pathway. There are actually reciprocal connections between the thalamus and the basal ganglia, and between the thalamus and the cerebral cortex. We won't go into that in detail this year. Our focus will be on that unidirectional flow system when we're talking about the direct and indirect pathways. So what do the basal ganglia do? Well, this is truly an open-ended question. An open-ended question meaning a question that does not have a static or fixed response. We are learning more about the basal ganglia constantly. They represent an important feedback circuit that influences ultimately cerebral cortical neurons. They do that by projections from the thalamus to the cerebral cortex. The basal ganglia, in terms of their movement, are required for the normal planning, the initiation, and the cessation of voluntary movements. Now, as I mentioned, we teach the basal ganglia classically as a motor circuit, and while it is indeed a motor circuit, it is much more than that. The basal ganglia has an influence on activities such as cognition, memory, limbic activities, and we'll come back to that briefly later in this presentation. So the individual nuclei of the basal ganglia are shown here, and what we're looking at is multiple coronal sections through the brain. The most anterior shown here, one about a centimeter or so back shown here. The anterior commissure is a nice landmark, and moving posteriorly, we see a little more of the basal ganglia, and finally our most posterior view, and we'll look at least three of these when we're illustrating the individual nuclei of the basal ganglia. To illustrate the basal ganglia connections, we're going to be using a rather crude template to basically map these out for you. So let's begin with the major receptive area of the basal ganglia. The major receptive area of the basal ganglia, once again, is the corpus striatum, or sometimes referred to as the neostriatum. It is composed of the caudate, the putamen, and the ventral striatum, which includes an area called the nucleus accumbens, actually an extension of a part of the amygdala. It is composed, just wanted to highlight those for you here. This is, of course, the caudate and putamen very far anteriorly before they've really divided, and a little more posteriorly now, separation of the caudate, bulging into the lateral ventricle from the putamen by the anterior limb of the internal capsule. The striatum is composed mainly of a population of medium spiny GABAergic neurons. These constitute about 85% of the neuronal population in the striatum. There is in addition a mixed complex population of large aspiny cholinergic neurons, and at least four categories or four subsets of additional interneurons, totaling about 15% of the neuronal population of the basal ganglia. This is again the major receptive area of the basal ganglia. It receives projections from the cerebral cortex, which are excitatory glutamatergic projections, and from the thalamus, which are also excitatory glutamatergic projections. It receives additional important input from the substantia nigra and the closely related ventral tegmental area, which are, of course, dopaminergic. The projections leaving the striatum remain within the basal ganglia, and they are entirely inhibitory. The major targets are the globus pallidus and the ventral pallidum, the substantia nigra, both subdivisions, which we'll come back to in a moment. Again, they receive input from the cerebral cortex, thalamus, and pars compacta of the substantia nigra. There are two subtypes of medium spiny neurons that you need to be aware of. The first is the so-called D1 subpopulation. It expresses the so-called D1 dopamine receptor. D1 neurons are excited by dopamine. They also co-express GABA, substance P, and dynorphin. They project to the internal segment of the globus pallidus and to the substantia nigra. The second major population of projection neurons are the D2 neurons, that is expressing the D2 dopamine receptor. They are inhibited by dopamine. They co-express GABA and enkephalin. Their projections go mainly to the external segment of the globus pallidus and the substantia nigra. Projections from both of these subsets of medium spiny neurons are inhibitory. This is, of course, the gross of the neostriatum that we saw earlier. And this is just a fluorescent labeled photograph of these predominant, numerically predominant neurons, the medium spiny neurons that project outside the striatum. So again, we're going to use this template to illustrate the connections. And in terms of the input, again, input comes from two major sources. I've omitted the thalamus to keep things fairly simple, but excitatory glutamatergic projections from the cortex and mixed excitatory and inhibitory projections from the pars compacta of the substantia nigra. Again, excitatory with respect to D1 neurons, inhibitory with respect to D2 neurons. The projections of the striatum, again, remain within the basal ganglia, D1 neurons projecting to the internal segment of the globus pallidus, D2 neurons to the external segment of the globus pallidus. There are some additional inhibitory projections that go to both divisions of the substantia nigra, that is the dopaminergic pars compacta and the GABAergic pars reticulata or pars reticularis. Turning our attention now to the globus pallidus, it is composed of two histologically identical segments. They have different connections and then some different functions, but they are populated exclusively by GABAergic projection neurons. We'll begin with a few comments about the external segment of the globus pallidus, which is, here's the external segment of the globus pallidus. I have it circled on the other side. It is separated from the putamen by a structure called the external medullary lamina. This is an area that is receiving inhibitory input from D2 neurons in the striatum, and it in turn is going to send inhibitory projections to the subthalamic nucleus. Here it is in diagrammatic form: input to the external globus pallidus, output predominantly to the subthalamic nucleus. And we'll come back to the significance of this in just a moment. There is also an internal segment highlighted here, and on this side, separated from the external segment by the internal medullary lamina. The internal segment is also composed of inhibitory neurons. It receives inhibitory input from D1 neurons in the striatum, and in addition receives excitatory input from the subthalamic nucleus. It will in turn then send most of its projections to the thalamus. Now here's the input in diagrammatic form, again receiving inhibitory input from D1 projection neurons in the striatum and receiving excitatory input from the subthalamic nucleus. And I promise this will make sense when we talk about the direct and indirect pathways in just a moment. Most of its projections, again, shown here, inhibitory projections directed towards the thalamus, depending on the particular basal ganglia loop. Those are different thalamic areas that are targets. With respect to the motor loop, the predominant targets are the VA and VL nuclei in the thalamus. The subthalamic nucleus, next, is populated by glutamatergic neurons. It is the only exclusively excitatory nucleus in the basal ganglia. It receives input from two major sources, and in the interest of full disclosure, I'll say that this is not the full story. There are many additional sources of input, but the major sources of input, and the ones that are particularly relevant to our talk today, are inhibitory input from the external segment of the globus pallidus and additional excitatory input from the cerebral cortex. The subthalamic nucleus in turn is going to send excitatory projections to the internal segment of the globus pallidus and to the pars reticulata or pars reticularis of the substantia nigra. This is a key component of the indirect basal ganglia loops that we'll talk about in just a moment. Okay, input to the subthalamic nucleus, and I've omitted input from the cerebral cortex to keep things simple and keeping our direct and indirect pathways discussion in mind. But the input to the subthalamic nucleus from the external segment of the globus pallidus is shown here. This is again inhibitory input. The output from the subthalamic nucleus, the major output, is illustrated here. The green excitatory signal heading to the internal segment of the globus pallidus. The substantia nigra, finally, is a mesencephalic derivative composed of two divisions. There is the pars compacta, the dark area that we can see grossly, populated by dopaminergic cells that, of course, in the adult give this section, this nucleus, its dark color due to the presence of neuromelanin pigment. There's an additional element that we can't identify too well grossly. You can get a hint of it here where my pointer is. This is the pars reticulata or pars reticularis. The substantia nigra pars compacta, once again, is populated exclusively by dopaminergic cells. Most of its input comes from the striatum, and it has reciprocal output back to the striatum. The pars compacta, the substantia nigra, modulates the activity of those striatal projection neurons that we talked about. And it does so by exciting D1 neurons and inhibiting D2 neurons. Now, to keep things simple, we can think of the substantia nigra pars reticularis or pars reticulata really as identical to the globus pallidus interna in terms of its neurotransmitters and connections. And in some of our circuit diagrams, just to keep things fairly simple to visualize, I'm going to go ahead and omit those connections to the pars reticularis. So again, in diagrammatic form, we have input to the substantia nigra coming from the pars compacta and reciprocal output now back to the striatum to both D1 and D2 neurons. All right, so what about these direct and indirect loops that we've been talking about? The so-called basal ganglia loops are unidirectional in the classic presentation, unidirectional pathways for the flow of information through the basal ganglia. The indirect and direct pathways have reciprocal, that is, opposite effects on the thalamus. One inhibits the thalamus, one excites the thalamus. Together, these pathways work together to modulate the degree of excitatory impulses that are leaving the thalamus destined for the cerebral cortex. And I would add here that these thalamocortical projections influence cortical regions in addition to traditional motor areas. Now, I would also mention that although these are traditionally taught as sort of separate parallel pathways, that is probably not the case. In fact, that's certainly not the case. There is evidence now that the direct and indirect pathways are actually interconnected at multiple levels and actually have an influence on each other. The scope of that, or a complete presentation of that, is they're inclined to say is beyond the scope of this review. And truth be told, it's beyond the scope of this reviewer. But I do want to make that point. These are not independently functioning pathways. So first of all, the direct basal ganglia pathway. The direct pathway is the major pathway whereby the thalamus is released from tonic inhibitory effects of the basal ganglia. The steady state, the baseline effect that the basal ganglia have on the thalamus is one of inhibition. The direct loop releases the thalamus from that inhibitory influence, and you will hear the term disinhibition to describe that. It begins with excitation of an intermittently active inhibitory neuron, a D1 neuron in the neostriatum. The D1 neuron, in turn, will project to the internal segment of the globus pallidus, where they will have an inhibitory influence. And the tonic inhibitory influence of the medial globus pallidus on the thalamus is therefore decreased, and excitatory signals to from the thalamus to the cerebral cortex will then increase. So here's what we're looking at as the first step. Again, pictured here is an excitatory projection coming from the cerebral cortex, specifically neurons in layer 5 of the cerebral cortex, to a D1 neuron in the striatum. This could be either the caudate or the putamen. That D1 neuron, in turn, is going to be excited. It's going to be activated by that cortical projection, and it is going to send a stronger inhibitory influence now to the internal segment of the globus pallidus. That inhibitory signal to the internal globus pallidus, in turn, greatly diminishes the signals, the inhibitory signals that are traveling from the basal ganglia to the thalamus. In other words, we're taking the brakes off of the thalamus. The net result then is a much stronger excitatory signal going from the thalamus back to the cerebral cortex. This loss of thalamic inhibition or disinhibition translates then as increased cortical excitation. What about the indirect pathway? Well, again, this has a reciprocal effect. It antagonizes the activity of the direct pathway. The projections include signals from D2 neurons in the neostriatum that go through the lateral segment of the globus pallidus and the subthalamic nucleus. So this is a much less direct pathway, hence the term indirect pathway. The effect is to increase inhibitory signals from the medial globus pallidus to the thalamus, which in turn will decrease excitatory signals from the thalamus to the cerebral cortex. So here's where we start again. But in contrast to the direct pathway, our excitatory signals now coming from layer 5 glutamatergic cortical neurons are influencing D2 neurons. They are exciting these inhibitory D2 neurons in the neostriatum. What this means now is that we have a much stronger inhibitory signal traveling to the external segment of the globus pallidus. What this means then is inhibitory signals that normally travel from the external segment of the globus pallidus to the subthalamic nucleus are decreased. This frees up the thalamus. It disinhibits the subthalamus, if you will, that in turn now can send much stronger excitatory signals to the internal segment of the globus pallidus. What does that mean for us in terms of basal ganglia output? Well, it means now that there is a much stronger inhibitory signal traveling from the internal globus pallidus or medial globus pallidus to the thalamus. This inhibitory signal then put the brakes on thalamic activity, resulting in a much weaker signal traveling from the thalamus to the cerebral cortex. Again, increased thalamic inhibition means decreased cortical excitation. So you can see here that the effects of the direct and indirect loops really act in a reciprocal fashion. Now, what are the functional domains that are influenced by these various basal ganglia loops? Well, there are, of course, classical motor loops. And I would point out, too, that if you read the literature, there are multiple different divisions that people have proposed for these basal ganglia pathways. For our purposes, I'm dividing it into 3 functional domains: motor, which is actually subdivided into several functional domains, an associative loop, and a limbic loop. Motor loop is the classic motor loop. The key players here are the primary motor cortex and the dorsal striatum, especially the dorsal or dorsolateral portions of the putamen. There is a premotor cortex, which gets signals now from the premotor cortex and supplementary cortex, and also interacts mainly with the dorsal striatum. There is an additional motor loop that is an oculomotor loop, whereby information comes from the frontal eye fields, again, mainly to the dorsal part of the striatum. Next, there is an associative loop, and this is an area that is getting its cortical input predominantly from the dorsolateral prefrontal cortex. It's also sending signals mainly to the dorsal striatum. This influences cognitive domains, the planning of future behavior, procedural learning, and basal ganglia injury can be associated with aberrations in cognition, in motivation, in procedural learning. And finally, we have a limbic loop. The limbic loop, its sources of cortical information are primarily the medial and orbital frontal cortex, which is sending projections not so much to the dorsal striatum, but to the ventral striatum, including the nucleus accumbens and the flanking regions of the ventral putamen and caudate nuclei. The limbic loop has a major influence on things like mood, emotions, reward-seeking behavior. Now, just as we talked about the fact that there are interconnections between the direct and indirect pathways, I would also point out that there are multiple interconnections between these functional loops. And this makes sense when you consider, for example, how a strong emotional signal that is processed through the limbic loop of the basal ganglia can influence something like motor activity, have a direct effect on the motor loop. Now, these aren't necessarily reciprocal. The motor loop itself doesn't have much in the way of effects on the limbic loop, but be aware that there are multiple connections between these functional loops. And I find this particular area, these additional domains and their interactions, one of the most fascinating areas of basal ganglia circuitry. Now, a few comments about disorders of the basal ganglia. These are a very important group of disorders historically. They provided us with our first real insights into the role of the basal ganglia in the control of movement. We can divide motor abnormalities in the basal ganglia diseases into hyperkinetic and hypokinetic disturbances. And many of these motor manifestations, not all of them, but many of these motor manifestations can be explained in terms of derangements in the direct and indirect motor pathways. Now, I would also point out, harkening back to our previous slide, that the clinical manifestations of basal ganglia disorders often include more than pure motor abnormalities. So let's begin with sort of a prototypic disorder, classically thought of as a pure motor disorder, hemibolism or hemibolismus. These are characterized by uncontrolled, spontaneous flinging movements of an entire limb. These will typically develop acutely, although there are exceptions to that. It is classically caused by a stroke that involves the contralateral subthalamic nucleus. There are other potential sources of injury, but classically, this is an ischemic event. Now, what derangements in basal ganglia circuitry account for the contralateral hyperkinesis? Well, let's begin by just reminding ourselves about the basic basal ganglia circuitry. Again, we have our direct and indirect loops, and I've included now for completeness those connections that are going through the substantia nigra pars reticularis. What is happening in the case of subthalamic injury is this. We ablate the subthalamic nucleus by whatever means, again, classically an ischemic event. And what's happening now? Well, we are cutting out these important excitatory signals that travel from the subthalamic nucleus to the internal segment of the globus pallidus and to the projection portion of the substantia nigra, the pars reticularis of the substantia nigra. What does that mean then? Well, we have now, by virtue of the fact that we have diminished these excitatory influences, we have greatly decreased the intensity of the inhibitory signals that are traveling from the medial segment of the globus pallidus to the thalamus. Now, the thalamus now has the brakes taken off. The thalamus is much more active than normal. That results now in increased numbers of excitatory signals traveling from the thalamus to the cerebral cortex. And that translates, of course, as increased motor activity. Contralateral motor activity, of course, because the motor cortex on this side of the body influences the contralateral, particularly the cerebral cortex influences the contralateral side of the body. So again, a classic hyperkinetic disorder. And I would also point out that recent reports have also documented behavioral changes associated with subthalamic nucleus injury and more recently with deep brain stimulation. So again, although this is classically thought of as a motor disorder, and indeed is a motor disorder, because of the basal ganglia's far-reaching influences, it actually may have an impact on more than classic or than isolated motor activity. A second classic hyperkinetic disturbance is Huntington disease. This, as you all know, is caused by abnormal expansion of CAG tandem repeats in the Huntington gene on the short arm of chromosome 4. This in turn results in the accumulation of excess polyglutamine residues in the Huntington protein. The mechanism whereby this injures neurons is not entirely clear. But the result is a progressive loss of GABAergic medium spiny neurons in the striatum. And for reasons that are still incompletely understood, there is a characteristic loss in classic Huntington disease of D2 neurons. And this will account, as we'll see in a moment, for the hyperkinetic presentation. Later on, both D1 and D2 neurons can be affected as the akinetic rigid phase of the disease ensues in the later stages of classical disease. The manifestations include, of course, movement disorders, choreiform writhing movements in classical cases, early onset cases, and later in the course of classical disease, these choreiform movements may give rise to rigidity. Another very important component, though, of Huntington disease, neuropsychiatric disturbances, and these may actually antedate the onset of motor symptoms. The neuropsychiatric disturbances in particular include depression, sometimes manic episodes, suicidal ideation, and these are complicated because, of course, the knowledge that one has Huntington disease is going to also predispose to depression. But again, I would emphasize that these symptoms can actually antedate motor disease, suggesting that there is an independent neurochemical basis for a number of these mood abnormalities. So what are we seeing in Huntington disease? Well, again, this is our classic intact circuit diagram for orientation purposes. And again, in the classic form, the hyperkinetic form of Huntington disease, early on, there is a selective loss of D2 medium spiny neurons that are projecting from the striatum to the external segment of the globus pallidus. So what is happening then in classic Huntington disease? Well, the thing that predominates here is a loss of inhibitory influences to the external globus pallidus. Taking the brakes off this nucleus in turn means that we have much stronger signals, specifically much stronger inhibitory signals, traveling from the external globus pallidus to the subthalamic nucleus. Now, what that means then is that our excitatory projections that normally go from the subthalamic nucleus to the internal globus pallidus and to the substantia nigra are greatly diminished. And so we have a much weaker signal, again, traveling from the internal globus pallidus to the thalamus. Take the brakes off the thalamus, increase thalamic activity, increased cortical excitation, therefore hyperkinesis. On the other side of the coin, we have hypokinetic disturbances, and the classic one that you're all familiar with is Parkinson's disease. This is a prototypic hypokinetic basal ganglia disorder. Parkinson's disease, as all of you know, is one of a growing family of alpha-synucleinopathies that includes sporadic Parkinson's disease, an ever-expanding list of genetic variants of Parkinson's disease, diffuse Lewy body disease, and multiple systems atrophy. Classic Parkinson's disease is associated with a selective loss of dopaminergic projections to medium spiny neurons. Both the D1 and D2 subsets are affected. The manifestations, of course, include hypokinesia or bradykinesia, a poverty of movements, rigidity, postural instability, a resting tremor, autonomic dysfunction, and very importantly, cognitive and behavioral changes, including anxiety, depression, apathy. So what's happening here? Well, let's go back to our intact basal ganglia circuit diagram showing in the normal situation the projections from the pars compacta to the striatum. D1 with its excitatory influence, D2 neurons getting an inhibitory influence. So what we're doing now is taking out those mixed excitatory and inhibitory projections from the pars compacta to the neostriatum. This has two effects. First of all, we are losing an excitatory input to D1 neurons. The D1 neurons, in turn, then are sending a much weaker inhibitory signal to the internal globus pallidus, which allows, in turn, a much stronger inhibitory signal to travel from the internal or medial globus pallidus to the thalamus. Basically, this is going to shut down inhibit thalamic activity, which in turn is going to result in weaker signals traveling from the thalamus to the cerebral cortex. Now, this is amplified by the effects of the loss of dopaminergic projections to D2 neurons. We are losing an inhibitory influence to D2 neurons, resulting then in a stronger inhibitory signal heading from D2 neurons to the external or lateral segment of the globus pallidus. In turn, these projection neurons from the lateral globus pallidus are now sending a much weaker signal to the subthalamic nucleus, which in turn sends a much more powerful excitatory signal to the internal globus pallidus. So this in turn is amplifying these powerful inhibitory signals that are going from the medial or internal globus pallidus to the thalamus. The net result, the same as what we saw with the aberration in the direct pathway, decreased thalamic activity, decreased cortical activity, and hence hypokinesis. Now, I would emphasize that not all aspects of the motor disease and motor aspects of Parkinson's disease are explained by this rather simple diagram. This does explain the rigidity. It does explain the bradykinesia, the poverty of movements. It does not explain the resting tremor very well, and the jury is still out on the mechanism for the resting tremor in Parkinson's disease. But again, this gives us an understanding, some insight into the bradykinesia. Again, Parkinson's disease is not a pure motor disease, and in the case of Parkinson's disease, even those that are not complicated by diffuse Lewy body disease, there are cognitive deficits, the apathy, the mood disorders that are associated with Parkinson's disease, in part likely have a basal ganglia origin. This last slide has absolutely nothing to do with the basal ganglia. It's just a pretty view from the Skyline Drive, looking sort of northeast over the Blue Ridge Mountains in the Shenandoah National Park. With that, I'll close and open it up to questions. This is, again, a complicated topic, and I'm not a neurophysiologist by training, but I hope this gives you a little bit of a foundation for understanding some of the clinical manifestations that we encounter in basal ganglia disorders.
Thank you. That was awesome.
Thank you.
So at this time, we're going to move into Q&A. You can submit your questions via the chat box, or you can unmute to ask a question. When submitting a question via the chat, please ensure the message is to everyone so that everyone can see it. And to unmute, select the microphone in the lower left. And after you've asked your question, please remute. So I'm going to go ahead and there's already a bunch of questions. So Mark Del Biggio says some anatomy purists recommend use of the term basal nuclei rather than basal ganglia. Do you have an opinion on this?
Yeah, that's true, and I understand the sentiment there personally. And I'm kind of a simple-minded guy in that area. I don't think it really makes a big difference. I think whatever helps you conceptualize what these are and what they do is fine. Terminology does vary, as do descriptions of what represent the fundamental components of the basal ganglia. This is what has worked for me, and again, I think has provided me with a foundation for getting a grasp on the basal ganglia and what they do. But admittedly, a lot of opinions about terminology.
Yes, for sure. Okay, so Mark Cohen says, thanks, Dennis. Excellent presentation. A favorite med student question is, why doesn't DBS suppression of STN activity cause hemibolismus? I usually wave my hands around and mumble about oscillatory balances. Is there a better answer?
I wish I had a good answer to that question, and I don't. I've discovered when lecturing medical students that I can wave my hand and try to make stuff up, but what I usually do is get called on the carpet for that. And so what I do in those situations is I say, that's a darn good question, and it's when I haven't sorted out. Why don't you do some looking, and I'll do some looking, and let's talk about it the next session. But no, I don't have a good answer for that. And I apologize. My knowledge about basal ganglia is far from complete.
Okay, so Charles Rhodes says, fascinating talk. Would you care to comment on the striosome/matrix organization of the striatum?
Yeah, that's a great question, and I actually did try to include some of that initially. I was told that my talk had to be 40 minutes long, so for that reason, I did not include it. But in terms of subdivisions, neurochemical subdivisions, the basal ganglia, the striatum in particular. These can be divided into what are called striosomes or striosomes and the surrounding matrix. If you stain these for acetylcholinesterase activity, there are fairly discrete islands that are devoid of acetylcholine related activity. The surrounding areas, in contrast, are rich in ACH activity, and this represents the matrix. The areas devoid of activity are the striosomes. Most of our medium spiny neurons actually exist in the matrix. There are some that exist within the striosomes. How those areas interrelate, I confess I did look into this before the presentation. Those interactions between the matrix and the striosomes and vice versa, and there are reciprocal interactions, still have not been crisply defined. But you'll hear that terminology, striosomes and matrix, and it's based again on acetylcholinesterase staining.
Okay. Maria Beatriz Lopez says, thank you, Dr. Burns, for this excellent review. Could you explain the targets of DBS and the pathways?
Deep brain stimulation to me, it's a complicated topic. And even though deep brain stimulation has been sort of standard procedure for treating a lot of movement disorders for some time, there's still a lot of uncertainty about how it acts. There is some evidence that the deep brain stimulation may actually have an inhibitory or ablative influence. For example, deep brain stimulation of the subthalamic nucleus. Again, harkening back to that earlier question, no, I don't know why it doesn't cause hemibolismus in those cases. But in some instances, you can think of it as having an inhibitory influence. And going back to those circuit diagrams, just ask yourself, well, what would inhibition of this structure do to targets? But that doesn't seem to explain everything. There are actually some instances where deep brain stimulation appears to have an excitatory influence. And again, this may go back to these periodic oscillations in subthalamic nucleus activity, for example, that was alluded to earlier. But all I can say at this point is that some of the observations just seem to be empirical. I'm not an expert by any means on deep brain stimulation, but I think you have to look at the clinical manifestations of deep brain stimulation and then backtrack and try to make up a story to rationalize it. But there's still a lot that, at least to me, is very poorly understood about how deep brain stimulation works, even though, again, it's a standard medical procedure.
Okay. So Jane Uehara Locke says, this is an extremely helpful presentation. Thank you very much for this outstanding presentation. And then next we have Edward Ploe. Thank you for the great presentation. In Parkinson's disease, ventrolateral SNPC degenerates most severely. Does this regional degeneration reduce dopaminergic projections to the striatum diffusely, or do these ventrolateral regions project to a subregion of the striatum? Are there functional differences in subregions of SNPC?
The answer, well, the answer to the second question is yes, there do appear to be some functional differences, but to my knowledge, the decrease in dopaminergic input to the striatum can largely be thought of as fairly diffuse. Certainly, the dorsal striatum is affected, that component that controls movement. But again, there's also evidence that limbic circuitry, that is aberrations in the ventral striatum, and its connections may also be affected. So my take on this is that, despite the fact that the early degeneration in these pars compactans in Parkinson's disease is regional, the effects, as near as I can tell, appear to be diffuse in terms of effects on the striatum.
Okay. And next we have David Munoz. Please use the circuit to explain the behavioral disturbances following treatment with dopaminergic agonists.
Okay. Well, dopaminergic agonists, as you know, can have, first of all, some definite motor effects. Hyperkinesis, just the opposite of what we see in untreated Parkinsonism. The behavioral disturbances that I'm most familiar with in Parkinsonism are in untreated Parkinsonism, and I've talked about things like apathy, a loss of motivation. My understanding is that with therapy, there can be additional mood disturbances that occur, manic type behavior associated with the hyperkinesis. And I think the only thing that I could suggest is that, one sort of would have to look at what the effects of excess dopamine on the normal circuitry would be. And again, manic type behavior is certainly one of those. I would emphasize too that there is still a lot of speculation about exactly what structures account for what mood aberrations. The anxiety in Parkinsonism, for example, is not well explained by circuitry that we've just talked about. So there's probably more to it than basal ganglia circuitry. And I'm sorry, I can't give a more complete explanation. I'm not a psychiatrist by training, but again, it would just be equivalent, I think, to dopamine excess.
Okay. I actually really appreciate these questions, because I actually think in the future, maybe we should have someone talk about mood disorders, right?
I think that's a great idea. I get made fun of sometimes for being kind of a neuroanatomy geek. But I think there are a lot of these basic questions that are fascinating and potentially relevant to what we do as neuropathologists. And I think, again, so much of this is going to be based on an understanding of anatomy and neurochemistry in these circuits.
Yeah. Yeah. So there is one more question, Howard Chang. How do you incorporate direct feedback loops from GP to striatum that are involved in this current functional model?
I'm sorry, say that again.
How do you incorporate direct feedback loops from GP to striatum that are involved in this current functional model?
Okay, I'm not sure
I don't understand the question.
yeah, I'm not sure I understand that.
Howard, you can unmute if you would like. Um, you can unmute if you would like to speak.
Yes, so there are direct projection from globus pallidus into the striatum, both
Correct.
dorsal globus pallidus as well as ventral globus pallidus.
That's true.
Right. So how does this work into your functional model?
The short answer is I don't have a good enough understanding to incorporate that into that basic diagram I presented. You are absolutely right. There are actually reciprocal connections that exist within the lentiform nucleus, and I don't know how to incorporate those. My apologies for my ignorance.
Hey, I think that's it for the questions. This was an awesome presentation.
Well, thank you. I am again very apologetic about the areas where I don't know very much. I wish I did know more. Even in retirement, I'm enjoying studying this and talking about it with folks. I will give a lot of thought to that last question about the effects on the models that we talked about today, the effects of those reciprocal connections in the metaform nucleus. I think it's an important topic.
Okay, awesome. Okay,
right.
I think.
Thank you again for joining us for today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Burns for an excellent presentation, and that concludes today's session. Thank you so much, everyone.
Thank you.
Bye, everybody.
Bye-bye.